Hey everyone, this is Steve from Client Gallon Home. I'm the staff developer there. I am contacting you today because we had some questions, recurring questions this week about some patient processes that I wanted to clarify. These are all really good topics and questions. I'll keep this very, very brief. I really wanted to send this out to everyone so everyone has the same base knowledge and processes on what to do. So, like we always do, we're going to break things down into RIP, resident rights, infection control, and patient safety. So the first topic I wanted to talk about is the use of bedbound. So I've been hearing a lot of nurses and nursing assistants using the word bedbound, bedridden. Please keep in mind that bedbound means that the resident is unable to get out of bed, not even into the wheelchair. It's actually more like bedridden, but bedbound and bedridden. Think of a resident who's on the end stages of hospice and is actively dying. It would cause too much discomfort and it is inhumane to transfer them to a wheelchair, right? Or a resident who has a severe pressure ulcer to their bottom and cannot put any weight on their bottom. They can't go on the wheelchair because of doctor's order. These residents are actually bedbound. They should not be getting out of bed. However, if the resident has some difficulty getting out of bed and they need some help, they are not bedbound. They're not supposed to just stay in bed. Okay, so this can be a dignity issue. That's why it falls under resident rights. It can be suggestive of neglect. If a surveyor were to talk to you and ask about what is this patient's functionality, describe this patient to me, and you use bedbound, even though the resident is able to get up with a Cerita lift, they may think, oh, this nursing assistant is just leaving them in bed. Okay, so be very careful about the word bedbound. Be careful about writing that on the whiteboards unless it's actually what they're supposed to be. So instead of saying bedbound, you can just say what the resident's function is, what their actual ADL ability is. So the resident needs two-person assist with the Hoyer lift, for example. And the next topic is a question. So this nursing assistant asked, if the resident is incontinent and confused, and is agitated and insists on using the restroom, what can you do? This is related to last week's last week's questions about not using the word, the sentence, just go in your brief, right? We can't say that. But what can we say in this situation? So think of the resident kind of like, I don't mean to compare them to a baby, but it's the same kind of way. A baby is not able to communicate that they need to get changed, that they are hungry, that they are wet, right? And so what does a baby do? A baby cries. And so in a very similar way, when someone is very confused with severe dementia, they're incontinent, and they keep telling you, I want to get up, I want to get up, I want to get up, I need to go to the bathroom, what they're actually communicating is, I am wet and I am uncomfortable, right? I feel uncomfortable. And it is uncomfortable to be wet and in your own fecal matter, right? So you can respond by saying, I understand you're uncomfortable, let me get you cleaned up. This way you acknowledge how they feel, which helps calm them down, and you focus on getting them cleaned up. So the goal is not to bring them to the bathroom because they can't go to the bathroom. Instead, it is helping them be clean and dry. So you're going to start with the pericare process. You're going to change their brief until they're all dry and clean, and usually by then, the resident will feel a lot better and will be calm. It's just that act of being wet that is causing some agitation for the residents. But still, as always, you cannot say, just go in your brief, okay? So please do not be saying that to your residents. Telling someone to wet their pants is not acceptable, so please don't say that. Next category is infection control. One question I saw was, if the resident's food tray arrives and the resident does not wake up, so let's say it's like a 7 a.m. breakfast tray and they don't wake up till 10, or otherwise the resident is unable to eat their food for a lengthened amount of time, what do you do with the food? I did suggest that you leave the food in the food tray cart to keep warm. However, the kitchen does want the food trays back eventually to prepare for the next meals or to clean it up and whatever. And so when you're unable to handle the food, keep the food in the cart, you need to store it somewhere, right? So I saw under the regulations that it is actually okay for the food to be left in the resident's room as long as everything is completely covered. And once the resident is available to eat, it needs to be reheated so that it's tasty for them, right? The limit is 4 hours. And so just a general guideline, breakfast time, that breakfast food must be thrown away by 11 a.m. Lunchtime, that lunch food must be thrown away before 4 p.m. And for dinner, it must be thrown away by 9 p.m. So you don't want it to be sitting at room temperature for more than 4 hours, because then bacteria will start to grow on it. If the resident is insisting on eating this food, just inform them, educate them, and say, I can get fresh food from the kitchen instead. There is already bacteria growing on this food because it's been sitting out for too long, so I do need to take it away because it is unsafe to eat. Okay? All right. So next question, still under infection control. Is it safe for clean or dirty gobies to be placed in the resident's sink during pericare? So during our audits, we did see a lot of nursing assistants in particular kind of setting up the resident's pericare or their oral hygiene or whatever, and they will fill up the sink with some hot water, and they will put the gobies in the sink and have it be wet and soaked in that kind of way. So this is not a good process because the surface of the sink is not a clean surface, right? It's kind of like putting the gobies on top of the surface of a toilet bowl, all right? The surface of the sink is not bleached, clean, it's not sterile. And so there are pathogens or sickness-causing bacterias on top of the sink. And if you take that goby and you put it in the patient's eye, or you put it on their peri area, it can cause pink eye. It can cause a UTI, right? So we don't want the goby to act as a vector. A vector is an inanimate, non-living object that can carry bacteria. So in that case, putting that onto the sink, the goby onto the sink, transfers the bacteria onto the goby, and you put it on the patient, and that's not good. So instead, you can prepare 2 clean plastic bags. And so one plastic bag will hold the prepared gobies for cleaning, and the second plastic bag, you will put the dirty gobies in. So if the way to imagine this is you open up one clean plastic bag, you go ahead and wet your gobies, wring them out, right? And that there's that one wet goby, you put it in that plastic bag, and then you wring out the goby with some soap, and you put it in that bag, and then you bring it to the resident to help with pericare. That second bag, once you're done helping clean the resident with the wet and the soapy gobies, you put it in the second plastic bag to be carried to the dirty utility, to the laundry. Whatever you do, please do not put the gobies onto any surface that is not the clean plastic bag. Someone even suggested to put it in a basin, and it is okay, except if there is fecal matter or dirty matter in the goby and you put it in the basin, that basin needs to be cleaned. And if you're day shift and you don't clean the basin and the resident uses it for something else, like for their face, that can be a huge infection control hazard, right? We don't want fecal matter in their face when they're getting prepared to go to sleep at night or whatever like that. So I would prefer the plastic bags. If you want to use the basins, the huge basins, you can, but you have to clean them after use. And everyone should know how to clean them because it is part of there was an education on basin cleaning and urinal cleaning. So if you have not watched that, please respond to this text message and let me know, and I can send you that education. But yes, plastic bags are preferred. And so the last question is under the category of patient safety. If the resident is newly admitted and I do not see anything on the whiteboard, are they bedbound until therapy refers them? And so there was a recent incident where a nursing assistant felt very pressured by the family member. The whiteboard did not have anything on it, and the family member and the patient really needed to use the restroom. And so they were pressuring that nursing assistant to get them up and transfer them, even though the nursing assistant did not get a report. There was also another case where the whiteboard was not updated at all during the resident's admission. And so that nursing assistant just assumed the whole shift that that resident was bedbound. Okay, we all know what bedbound is, right? So these are not correct processes. As a nursing assistant, as a nurse, you really cannot touch the patient or do anything with them unless you get a for sure report. The admission nurse is responsible for talking to the hospital that is sending the patient and getting that report, which includes how to transfer them, how they use the bathroom, etc., and putting it on the whiteboard. And so if the resident comes and you do not see anything on the whiteboard, I recommend that you prioritize getting that information so that you know how to take care of the resident in the event that you need to move them around, in the event that you need to help them eat, etc., etc. Okay? If the family is really urging you to get them up, you have to be firm and protect your license, protect your certification, okay? It is better to have an incontinence-related incident, incontinence-related accident, than have a fracture-related one because you moved them and they fell and they hurt themselves. And we all know that family members and patients are not always the best historians, and they may not necessarily follow what the doctor tells them. So you got to protect yourself. So if the family member or patient is pressuring you, just say, I understand the urgency, but I do need to do my job and get my report first. I will get report from the admission nurse right now, and I will be right back. So you show them you understand that it's urgent, but you also need to make sure that you do your job and not hurt them on accident. Okay, so thank you so much for listening to this audio. There is no post quiz. I just need to send this out to make sure everyone is aware of what to do. And I want to answer all these questions because I keep getting them and I want everyone to be on the same page. If you have listened to this audio and you completely understand and you're at the end, please type mango, M-A-N-G-O, like the fruit. Type that into the text to confirm that you have received this message and that you understand what I talked about. As always, if you have any questions, please let me know. I am free to text anytime. All right? Thank you and have a good night.